According to a 2020 study, race-based medicine can be defined as the system by which research characterizing race as an essential biological variable translates into clinical practice, leads to inequitable care. However, race-conscious medicine is an alternative approach that emphasizes racism rather than race as a key determinant of illness and health, encouraging providers to focus only on the most relevant data to mitigate health inequities. Health equity is a guiding tenet here at the network, as you've heard us talk about today, and so we're very pleased to have Dr. Eileen Wang help us apply this approach within the context of asthma care. Dr. Wang?
Thanks, everybody. All right, so we're talking about spirometry and race-neutral parameters, the impact, particularly thinking about communities of color with asthma. I have no pertinent disclosures. And I have 4 objectives today. So first, we're going to understand the role of social determinants of health in asthma disparities and health inequities. I know a lot of you all know this, but this is really important to highlight because it's the lens through which we're going to understand why we have this basis for change from race-adjusted to race-neutral spirometry equations, and then what kind of impacts we're seeing because of that on communities of color. We're also going to address considerations when adopting race-neutral spirometry, and then we're going to talk about that shift to race-conscious medicine and what that means. So this slide reminds me, I gave a presentation to a bunch of middle schoolers not too long ago. And my daughter, who's in 5th grade, was giving me tips, don't do this, don't do that. And it was starting to get me really stressed out. And I thought it was actually particularly funny because I gave a presentation that same week to a crowd full of like a couple hundred pulmonologists, and then I was going to give a talk to about 20 middle schoolers, and I was by far and away more stressed out for the middle school presentation. But what I loved, when I was talking to them, I asked them, what does health equity mean to you? And they came up with this, that everyone has a fair opportunity to be healthy. And I thought that was just so beautiful. The WHO also mentions as the absence of unfair, unavoidable, and remediable differences among groups of people. And the CDC notes that achieving this requires focused and ongoing society efforts to address historical and contemporary injustices. And I think that last part is so important. There's been historical injustices and there's ongoing injustices. We need to think about that. That's why in reality, there's no pointer. Oh yeah, there's no pointer. In reality, the support systems, there's inequity there. Equality, everybody gets the same thing, but that's not what everyone needs. Equity is that people are getting the nuanced support that they actually need, and ideally we move to justice, where we actually remove those injustices, we right those injustices, and we remove those structural barriers. This is really an exciting time to be talking about health equity. Not only were these middle schoolers, they just knew this. This was what they had heard about, they talked about it, and also I'm involved in the fellowship, recruiting fellows into our program for Allergy, Immunology. And it's so invigorating because so many of them are interested in this topic. Such a huge change. So there's been great work before us, showed a lot of evidence health inequities exist. Hopefully no question to that. And then, but what the areas where we still have knowledge gaps is that we still don't quite understand, well, how do we then develop effective strategies to mitigate and reduce these disparities? Every community is unique. There's strengths, resources, and different barriers in each. So really, this is the time. I say this is invigorating. If you want to join in this, this is a time where we're going to shift towards health equity. We're going to work towards trying to achieve this, and we're thinking about the development, the implementation of these strategies, dissemination, spreading the word, and also thinking about the different levels. Communities, again, unique communities, they should really be the drivers, but also thinking about regional and national levels, and then global. We can't really talk about health equity without talking about social determinants of health, which has been mentioned quite a bit. But here we have the WHO definition. That's the conditions which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. And this also makes me laugh a little bit because when I present a similar slide to the middle schoolers, they're almost like, well, duh, this makes complete sense. But what I think is really important, especially for those in science and in the medical field, is to understand that this was not, maybe we understood that it has some impact, but I don't think we fully understood how significant these impacts are. These are truly such strong determinants of health and disease. So the WHO, I love this quote too, that addressing these social determinants of health appropriately is fundamental. You cannot ignore these. For improving health and reducing long-standing inequities in health, and this last part, which I should have bolded because it's probably my favorite, which is requires action by all sectors in civil society. This is something for everyone to do. For those who have been, communities who have been disproportionately burdened by these health inequities, they have the furthest to come up and to benefit, but everyone benefits when everyone in the community has that equal opportunity or that equity, that opportunity to achieve good health. So the Healthy People 2030, and kind of breaking it down into more concrete areas, we think about healthcare access and quality. That's a social determinant of health that has impact on health and disease. The neighborhood and the built environment, we heard so much about the importance of the home in mitigation, the built environment, but also about climate change and how some communities are disproportionately impacted. Social and community context. And remember, we're not just thinking about disproportionate burdens, but we're also thinking about strengths and resources. Economic stability, huge impact, and also education access and quality. I love this study. Hopefully some of you are familiar with it. If not, it was a study that was with the Severe Asthma Research Program. It was published in the Journal of Allergy and Clinical Immunology in 2019. And what they did is they looked at children and adults with asthma who were presenting to the emergency room for an asthma exacerbation. And what they found here is that, yes, okay, they're seeing racial disparities. Particularly, they're in this article, they're focusing, Black participants had about twofold higher rates of going to the emergency room for their asthma, and also more severe exacerbations, ones where you needed hospitalization and treatment with steroids. But then when they considered community features, family socioeconomics, environmental exposures, and what's in the home in terms of pets, pests, pollutants, smoke, and the age of your home, that went away. That explained the disparities. So you no longer saw these racial disparities anymore because they were explained by these social determinants of health. And so I do like to say that again, racial disparities were explained by social determinants of health. And this is not the only study to show something like this. What's really, I think, positive about this is that social determinants of health and these factors, these are intervenable. You can do something about that. We can have interventions, we can have policies that can help to impact. Also can't talk about health equity without talking about systemic and structural racism. So the structural racism is the ways in which society facilitates discrimination through the creation and reinforcement of inequitable systems, policies, and sanctioned practices. So, what does that mean in concrete terms? It's helpful to think about certain pathways that this manifests, but this is not comprehensive, but residential segregation, physical and social hazards, chronic psychosocial stress, some great research out in there, and also historical practices and injustices along with ongoing. This is something historical redlining, hopefully as a review for most, but this is the map of Boston. So this is a historical map of redlining in Boston here. And so it was a practice, it was a discriminatory practice that occurred starting in the 1930s and went all the way through the 1960s. So we're talking about 3 decades of discrimination. And it was a systemic structural discrimination, affected over 200 cities in the US. And essentially what they did is they graded communities from A being the best, the most desirable, to D being, the least desirable. And how communities got the D rating when they were redlined is based on whether there are communities of color there, immigrants, communities of color. And so what ended up happening is Sally Wenzel and Dr. Wenzel and her team at the University of Pittsburgh did this really amazing study where they looked at the redlining in Pittsburgh, and it's just to show that this still has impact today. So her study looked at A through D, and then they looked at the air quality there. So A, best air quality, D, worst air quality, okay? And then they looked at asthma outcomes. A, best asthma outcomes. D, worst asthma outcomes. And so she has a really poignant way of saying it, where her conclusion and her team says, the racist practice of historical, or HOLC, which is the Homeowners Loan Corporation, redlining, profoundly contributes to long-term environmental and asthma-related inequities in Black adults. Acknowledging the role racism has in these outcomes should empower more specific and novel interventions targeted at reversing these structural issues. So things in the past still have impact today, and we have to address these injustices. But then how do we do it, right? How do we address race and ethnicity? If we can explain it away with social determinants of health, these racial disparities, does that mean we toss it out? It's like, no. Race and ethnicity are really important social constructs. But the key here, with that wonderful introduction, it's a poor reflection of biology. So race, ethnicity, important social constructs, poor reflection of biology. But then people always say, well, what about genetics? Doesn't race, reflect some of the genetic predisposition that we have? It's like, well, studies have shown that there's more genetic variation within a race than compared to between populations. And also, it's not to say that genetics is not important, but that, genetic ancestry is more predictive, but genetic ancestry does not equal race. So race, again, important social construct, but it doesn't equal our genetics, our biology. So that sets the stage for how did this happen? Because if you think back, hindsight is 2020, the framework with which we shifted from race adjusted to race neutral, that's so important. So how race was or is still being used in some places is that the reference values for pulmonary function were adjusted for race and ethnicity. And then the rationale was, well, racial and ethnic minoritized groups are presumed to have varied lung function on the basis of this epidemiologic data. They saw the disparities there, so they said, oh, that must mean biology, so we're gonna have these adjustments for race. The harm that we're seeing is that poor recognition. You can imagine you're not picking up on people who might have asthma early enough, and also you're not detecting how severe they might be. And then that also has downstream effects in terms of the support and the services that they can obtain, including disability, workers' compensation, and just appropriate care. What is the race-conscious approach? We don't toss out race, but we understand that we're going to use unadjusted measures, so race-neutral equations for lung function for all patients, and then we're going to counteract existing biases that harm patients of color because of these racial existentialist beliefs that race equals biology. When I realized I've been talking for too long, it's like, I'm going to quote someone who's so much more eloquent and can say this. So this was published in the New England Journal of Medicine, and these authors say, to be clear, we do not believe that physicians should ignore race. Doing so would blind us to the ways in which race and racism structure our society. However, when clinicians insert race into their tools, they risk interpreting racial disparities as immutable facts rather than as injustices that require intervention. Researchers and clinicians must distinguish between the use of race in descriptive statistics, where it plays a vital role in epidemiologic analyses, because you still want to be able to see what's going on, and in prescriptive clinical guidelines, where it can exacerbate these inequities. So as we've come to understand the importance of shifting from race-adjusted to race-neutral, there's been some great studies coming out and letting us know, well, what was the impact of these race-adjusted spirometry? Because again, this was the norm. So this was just taken as, okay, this is how we should be doing things. But now we're seeing that more data showing it's leading to that underdiagnosis or misdiagnosis, as you can expect. And what are the trickle-down effects of that? Reduced access to important therapeutics, for example, biologic therapy, worsened health outcomes, as you can expect if you're not picking up on the disease or the disease severity, and also decreased eligibility for important supportive services like workers' compensation, disability, among others. All right, here's a wake-up question. Yeah.
Yes. All right, poll time, everyone. Online folks, I hope you are ready. Which approach do you believe is more effective for spirometry measurements? I have 146, So let's get it in before Bethany reveals our results at 1:47.
If you get it wrong, I will only judge you. Just kidding. I'm just joking. It's anonymous, I don't know. Which of yous were snoozing after a good lunch?
Okay, so I have A, 56% of us said race neutral spirometry, and then B, 20%, and C was 18%, and then D was 7%.
All right. Well, thank you so much for answering that question. The answer here is, we're going to talk about some of the data. It is race-neutral spirometry. So for those of you who are, not quite convinced, I have here, in science and data, we always try to, even things that we assume, we want to prove it. And so more and more data is coming out that race-neutral equations for spirometry is equal to, at least equal to, or superior to race-adjusted spirometry. So studies looking at, so they took a lot of data and they looked at, okay, well, now let's reinterpret a bunch of patients and their spirometry, and then let's use the race-neutral approach. And what they found is it better reflects the risk of mortality across the races, so that's an important matchup. It better matches symptom burden, airway disease, and physical function. So this seems to be a better equation to be able to match up with the things that we find are important to us as clinicians, to advocates, to patients, to their families. Hopefully that convinced some of you. Otherwise, we can dig in. And if you're not convinced by me, then the European Respiratory Society and the American Thoracic Society posted an update, published an update in 2021, and I do love some of their language here where they say the historical approach of fixed adjustment factors, so that's the race adjusted, for race is not appropriate and is unequivocally discouraged. How often do you see in science and medicine where we say unequivocally? It's such a wonderful, powerful word. And then there's more emphasis on what we know is incomplete understanding of the role of race ethnicity on lung function. And there are ongoing efforts to better understand these geographical, environmental, genetic, and social determinants of health that play a role in explaining these observed differences. So again, these differences don't necessarily equate biology. So let's figure out, well, where did this all come from? So 2005 is where we're getting the race adjusted, and 2021 is where we're getting the race neutral. So looking at 2005, it was based on data. It was based on the National Health and Nutrition Examination Studies, or NHANES 3. And they used from that data, they created these racial and ethnic specific equations. And it's also important to note, for bronchodilator response, there's some differences in the interpretation, meaning they're at 12% or 200 milliliters. 2021, when they moved to race neutral, it's based on the Global Lung Function Initiative. And we're going to dive a little deeper into some of that data. And there's no racial or ethnic specific equations, and there's that emphasis on the incomplete understanding of the role of race ethnicity on lung function, so the need for more research and understanding. Bronchodilator response is greater than or equal to 10% FEV1 or FVC. And also they have a clarification too that biologic sex assigned at birth, not gender, should be used to interpret lung function because of the match with physiology, or better match, I should say. So again, for race adjusted, that's the NHANES 3, 1999, that's the data it was based on. So it was based on 7,429 patients, had kids and adults ranging ages 8 to 80, and all the patients were from the US, so it was a US study. Race neutral is based on GLI 2012. So this is a study that included 10 times more patients, so 1,057 patients, a little bit more of an age range from age 3 to 95, and you can see the geographic diversity here. Patients from 77 centers in 33 countries. So you have increased numbers, increased age range, and increased diversity, at least geographically. So, I think this is, oh yeah, it's not the updated. That's okay. Maybe it's further? No. Oh, that's okay. So I did update because I realized I made a mistake. But the updated slides, what I can still show here is you can use a calculator to see what the difference is. So if you input the same age, the same height, the biologic sex assigned at birth, and all you do is you change is the race into a calculator, you can see the impact of using race adjusted. And these ones are a little bit off because I realized I made some mistake, but you can see if you input the same measured liters, so 1.8 liters for that FEV1, and that percent predicted for African American, you see is about nearly 80% of predicted. If you adjust it and you change the race, everything else is exactly the same. For Southeast Asian, you can see a little bit change there. Sorry, no pointer, but it's 78% on that far right side of what's predicted. Then when you do race neutral, you can see that this, what you thought maybe looked pretty good for African American, like 80% isn't great, but it's not terrible. Neither is 78%. But you can see race neutral shows that, hey, their FEV1 is actually only about 72% of what would be predicted. And so you would think that that would cue you, the patient, the clinician, the caregiver, to say, like, maybe this isn't as good as we would want it. So these are the impacts. And if the revised slides get sent out, you'll see I also include what happens when you input that they're white or Caucasian. So you have a diagnosis of airflow obstruction. If you want to do this for yourself and for everyone out there, you can there's a GLI calculator. So again, you input that age, the height, sex assigned at birth, and then you can pick race neutral, Caucasian, African American, Northeast Asian, Southeast Asian, or other. And then you get to see what that does to your, you would input, ideally your own or your patient's, and then input the FEV1, the FVC, how much they're blowing out in liters, and you get to see that change happen. So this is, again, that pitch to, let's, think about that shift to race-conscious medicine. And it's really to help understand, like, how did this happen, right? Hindsight's like, wow, we should have been race-neutral for so long. How did we do race-adjusted? And why are we only now talking about it? And it's based on that race-based medicine. So race was ill-defined, and then it was thought to have biologic significance, because we weren't thinking about social determinants of health. So then, when you look through that lens and you see epidemiologic data, clinical data showing that there is a difference, you then infer, oh, this is just biological, they're different. Different communities of color have different disease and different physiology. And so that perpetuates these biases, stereotypes, and leads to further inequities. And then that reflects also in terms of basic and translational health. If you have that lens at race equals biology, you see, okay, I see differences here, and then that informs clinical practices, and it continues to perpetuate these inequities. But what's different here is race-conscious medicine is that you understand it. Through all these studies that we're showing that social determinants of health really explain these disparities, is that it's a really important social and power construct. So then you start to think, well, what is going into that? There's structural racism there. Let's look at that. And when you start to understand the consequences of these social determinants of health, structural racism, you start to think about what supports are needed to address these barriers. And that then leads to reduction in health inequities and that movement towards health equity. So how do we move forward, right? This is a big change, race-adjusted to race-neutral spirometry. So as patients, as clinicians, medical care providers, advocates, is to ask to compare those absolute values. So that's your liters, right? How much you're actually blowing out in that 1 second for the FEV1 and the total for the FVC and the ratio there. But it's also important to note, I mostly see adults, so it mentions adults here, that unfortunately as we age, our lung function declines. We do have to adjust a little bit for that. But then also to alert and explain the rationale for this change. There needs to be transparency here. So that may impact diagnoses, right? Someone you didn't think had asthma before now does look to have asthma. Or maybe you thought it was pretty mild, but it's actually more severe. And then also to utilize statements. We utilize it at our hospital, but just to update folks on why there is a change. Why didn't they used to have, if they were blowing out 2 liters and that used to be 80% for them, now it looks like it's only 72% of what would be predicted based on their age, their height, and their sex at birth. Community outreach is huge. Really need to partner with, with everyone here to spread the word, advocate for race neutral, be able to explain this, and also consider the impact of shifting to race neutral equations. And we do need continued research for better understanding. But in order to do that, as you heard, we need to increase the diversity of research participants. Easier said than done, right? We need to earn, as a medical and scientific community, needs to re-earn that trust. There's a lot of reasons for distrust, and I'm gonna make a pitch for community-based participatory research, which essentially is a form of research that is equal partnership between the community and the researchers, because who should really be identifying and driving how we are approaching these barriers and structural, racism? It should be the community, right? Every community is unique and there's different needs there. But that takes time and that takes trust. So key points here. Disparities, racial disparities have been explained by social determinants of health. I gave one example of one really nice study, but there's others. Impacts of structural racism are pervasive, and we need to shift to race-conscious medicine. We talked about the rationale for race-neutral spirometry, the bigger study that it's based on, and also the impact on communities of color with better alignment with, predicting risk of, symptoms, of morbidity, mortality. And then the importance of having these open and transparent discussions about why. Why did we go from race-adjusted to race-neutral? And the importance of outreach and advocacy in these partnerships. And if we haven't, then to advocate for that we should be moving to race-neutral equations. But then we were still, as we're moving to race-neutral, we need to understand what are the effects on the communities. And then with that, that greater diversity of research participants and that partnership with community is really key there. Any questions?
Thank you, Dr.
Thank you. Oh, yeah.
So questions, I know we have plenty of questions.
Oh.
You want me to ask my question? So I'm Dee Dee Gardner. I'm the Chief Research Officer here at Allergy, Asthma Network. And my question is this, is that when we're thinking about race-neutral parameters, is that if the people in the audience are practitioners who are not a physician, are maybe out in the community providing spirometry, what do they do if the devices they're using don't have GLI as an option?
Right, that's a fantastic question. So that's a practical, right, software that our spirometers come with. A lot of times you have to input age, the height, the race, and the sex. And so I would actually recommend, that's why bring up that GLI calculator, because you can do that manually. It just takes a few seconds. There is a little bit of an annoying feature in it. It always makes you prove that you're not like a robot, and so you have to keep clicking the thing and sometimes identify the buses. But it helps because, right, the software might have not come through. We're hoping, especially with ERS and ATS, like standing behind this for multiple years now, right? That was 2021 that they put that statement out. We're already 3 years in that, more software will be having these updates for that option, and that won't be as costly, right? Because any big change takes effort, takes time, takes money. But that calculator you can use that.
Any online questions?
We do not have any online questions.
All right, thank you.
Thank you so much.